Hi, good afternoon, everyone. Thank you so much for joining us. My name is Malika Hofstad-Retner, and I am one of the event managers from Practice Tech. I'm so pumped to welcome you to the Gaidge Q4 virtual event. We've got an exciting session lined up for you today, all about taking your clinical operations to the next level. Andrea Cook is going to show you how to harness the power of Gaidge Analytics to drive meaningful improvements. We're going to dive into clinical reports so you can master the treatment efficiency board and uncover strategies to streamline your workflow like never before. Now, before we kick things off, I want us to get a little cozy with our virtual space, our venue on Livestorm. So if you look at the bottom of your screen, you'll find that there's a questions icon and a chat icon. So you'll drop all of your webinar questions into that little questions icon, and then everything else you can save for the chat. Like, we'd love for you to tell us hi and tell us where you're coming in from today. So you'll also have access to the instant replay as soon as this event is done. So as soon as we log off, you have instant replay access. You'll also receive an email that gives you that same link again. Now, we all know that Andrea Cook needs no introduction. With over 20 years of orthodontic experience, she's a powerhouse clinical consultant and trainer known for her engaging hands-on approach. Andrea turns complex topics like OSHA compliance, sterilization systems, and clinical efficiency into actionable strategies that transform practices. Drawing from her background as a clinical coordinator in high-volume settings, she's a pro at streamlining workflows and enhancing team communication. Now, after joining the Gaidge 360 team, Andrea uses her unmatched expertise to boost productivity and guide clinical teams towards excellence. So she's your go-to for orthodontic success. Thank you so much, Andrea, for joining us today, and you go ahead and take it away.
Well, thank you so much, Malika. Excuse me, and I want to thank everybody for joining me. I know this is a busy time of year. You guys all have a lot going on. It's the end of the year. It's holidays, everything. But I'm so thankful that you are here to join me. Now, one of the reasons I partnered with Gaidge, I still have my consulting business, but Gaidge is such a valuable piece of information. And oftentimes I feel it doesn't get implemented or used well. So my goal is to give you the understanding of how to use it, the data that you can pull from the Gaidge dashboard. We're going to talk about that. And then what to do with some of the data that you do get if it is at a level that you don't like. So let's get started. So a little bit about me. So I started chairside when I work with my offices. I said it was different back in the day, but it's also so much of it is still the same. So I understand the pain points that you guys are dealing with. The areas on the right are things that I deal with offices, whether it's sterilization, OSHA, digital workflow. This data, anything on your clinical efficiency side is the area that I get to work with. And I love my side of the practice. So a little bit about Gaidge. Gaidge is when I first met Gaidge, when it first came out, I was so excited because all of the information that Gaidge harnesses and gives to you is based on facts. They go in, they gather the data for you, and they feed it to you in small bite-sized pieces. So we have something that we can actually do something with if we know how to harness. So that's the goal for today. It's a powerful tool. There is so much information there. But like I said, unfortunately, I go to a lot of offices and I'll ask them about their Gaidge and who's managing it. And especially on the clinical side, nobody is. They don't know how to sign in. They don't know what's involved. They don't know what's in there and how to extract it and how to digest it. So it's a powerful tool, but it's got to be managed. We have to have somebody that is in there understanding it, reading it, and not just understanding and reading it, but setting up a plan for, okay, we see this number is changing and it's changing in a direction we don't want it to change or we don't like. What are we going to do about it? What are steps we can implement instead of just saying, oh, our emergencies are higher? That's not what I want. Typically, I have one team member in the office that is designated to being the manager. I like everybody to be involved in projects. I like everybody to understand it, especially now that we have a lot of movement in our offices where you have people coming and people going. So I want one team member to really understand it and to be the manager of it, but I want everybody on the team to know what's involved. If that person decides that they need to stay home to take care of a baby, whatever it is, somebody is right there behind them, knowing what to do and reading the information. It doesn't just get forgotten. Whoops, went the wrong way. Okay. To thrive in today's consumer-empowered environment, brands need to be delivering the best possible customer experiences. And the big thing is when, where, and how the consumer wants it. We don't treat patients how we want to be treated. We treat them how they want to be treated. A lot of the ways that we are registering our treatment efficiency may not resonate with them. So we want to make sure that the way that we are addressing them is treating them. One of the things I work with is the difference between fact and opinion. A fact is something we can prove, and that is what Gaidge gives us. Gaidge gives us the data that says that as long as the data that you put into Gaidge is good, then the data that you pull out of Gaidge is going to be the same. It's going to be accurate information that we can manage and we can do something about. So when we talk about emergency tracking, I track by procedure, patients in extended treatment, and then procedures during treatment, number of procedures. With anything that you track in your practice management software, we have to have accurate data. We have to make sure that things are going in consistently, that my clinical team members are coding things consistently. And if there is a change in procedure, that's changed. If we do additionals, if we aren't tracking those codes and that consistently, then the data that we pull out is going to be as cloudy as what we put in. So we're not going to be able to implement changes as well as we could if we had accurate data. Now, once we have those codes, I want to make sure that our schedulers are scheduling correctly. We want to make sure that if I say this is the code that I need, that's the code that I get. Don't say, oh, I think she can do that in 20 minutes because mom wants a 4 o'clock. We can't do that. When we start running these reports, we can start looking at our statuses. Now, in our statuses, we want to make sure the triggers are set so that status changes happen. So if we do an initial bonding, then it's going to trigger a status change into whatever treatment they started with. If we do a D-band, it's going to move them into retention. When we look at some of these reports, if they are not the status changes are not correct, that means our triggers are not being put in, our codes are not being put in properly. So those are signals to us that things aren't correct. Oh shoot, this is in PDF. So when we look at your dashboard, I forgot about this. When we look at your dashboard, on the left side, it'll say dashboard. Now up on the top, it's going to have your time period set. You can set that as your default as far as what do I want to track? Do I want to look at last year? Do I want to look at last month? What are the data that I'm going to look at? Then on the other side, you can sort it by, on this side, there will be a tab and you can sort it by practice, by location, especially if you have a practice that has multiple locations, you can see what the trends are for multiple locations, or you can isolate one location to see how they are doing. So your dashboard is going to give you snippets of information for you to say, okay, and the SMLY is same month last year. So you can tell which way you are trending. If you want to be trending down, your patient's overestimated completion date, we want that number coming down. So if it is trending down, great, we can manage it. So these are two tabs that we're going to focus on today. So in your reports tab or section on the left, the two that we're going to be talking about today are the schedule tab and your treatment efficiency. Now, under your schedule tab, there are things that probably other team members in your office will be focusing on. your schedule stats. That's usually handled by your schedulers or practice manager, somebody like that. We're going to be looking at your repair detail, your patients beyond estimated completion date. We're not going to look at active patients with no appointment. And on your treatment efficiency tab, we're going to be looking at D-bonds, starts per visit, or starts per D-bond, your value per visit, and your estimated versus actual months for completion. So that's the area of the clinical focus that we're going to be working on today. So when we look at your repair detail, you're going to get a report that looks like this. The purple bar is the total number of repair visits that you saw during a month. Now, the colored bar on the right side is going to give you a breakdown of what happened within that total. So if your red is bond problems, it is going to give you the number of bond problems that you had. And it's going to tell you how that compared with the same month last year. So you can see on this practice, their bond problem was at 32, and it was up 25% from the same month last year. Something you might look at with that is, do we have new adhesive? Do we have new team members? Do we have new curing lights? Why is it up 25%? Wire problems are up 44% from the same month last year. Broken appliances, those are down 58%. That's great. The closer the two bars are to the same height, the more accurate your data is going to be. So if you clocked 92 repair visits, but you only have a total of, some of these are at, 75. So if we look at January, 110 procedures were coded repair visits. Only 75% of those were categorized. So we have a lot that fell into the abyss of, I don't know what happened. So we need to make sure the clinical team knows what those codes mean and what it can mean for solutions for your practice. Oops, wrong way again. This bar will give you monthly what you did. So you can see on a monthly basis, was it up, was it down, what happened within that. So you can see trends. Like I said, did we have a new adhesive and it jumped up? Did we have new curing lights and it dropped down? So you can follow that bar across. So your emergency tracking. When I look at emergencies, I want to know the number of emergencies that you saw. I also track breakage at appointment. So if you have a high percentage of patients that are showing up for their appointment and just have something loose that we have to deal with, then I want to track that as well. All of these will have a procedure code that can be extracted by Gaidge and fed into these reports to funnel it down and give it to you, like I said, in bite-sized pieces so that you can do something about it. The goal is about 5% of your patients seen per day, or appointments seen per day, should be an emergency. If it's higher than that, we want to get into why is it higher than that? So in your tracking, most offices will have 2 SOS emergency comfort visits, whatever your office calls it. They'll have a long and a short. These are for your schedulers to put in. Johnny calls in, or Johnny's mom calls in and he says it's a color off or a wire clip. I'm going to put him in a short. If it's a bracket off, I'm going to probably put him in a long. That's fine. That's to help your schedulers decide what length of appointment they need. Now, clinically, we're going to break that down into what happened within that long or short, so we can tell how many brackets did we have loose, how many loose appliances, what was the focus of what caused that number to be high. You can also have a code for repair inside a regular visit. So that will tell you that Johnny came in for his appointment today. He had something loose, and I still count that as a loose bracket or emergency. But we also want to make sure that we keep that adjustment appointment coded. That's for your numbers for building your schedule and your templates so that we have enough of those adjust appointments. So we don't want to take one of those and turn it into an emergency visit. So your practice management software will show your procedure counts by month, And it will tell you what happened within each of those months for each of the procedures that you posted, and it will give you the total. So if we are coding properly, this is a good report for us to run within our practice management to make sure that we are tracking properly and see what happened within a year. So emergency visits. I would encourage you to take emergency visits out of your vocabulary in your office. We can have comfort visits. And then determine what constitutes who needs to be seen today. If we have an emergency visit, is it plain bleeding? When I work with offices, before I go for a consultation, the team members will send me a filled out questionnaire. And one of the things that they want is consistency with what happens with patients who call in, show up late, have loose brackets, have problems. They want to know consistently, what are we going to do as a team? There's also, we have to be kind of aware of special circumstances for extenuating circumstances, but we want to make sure that we have some type of guidelines and guidance for us to get started. So we know that comfort visits can add treatment time. If they are coming in for emergencies and we are not progressing through their treatment, that's going to mean there's going to be longer treatment time, and we'll talk about treatment time. We know what it does to disrupt your daily schedule. And we also know what patients are talking about on the soccer field or the baseball field, whatever field you're on or whatever event you're at. As far as we go to see Dr. Cook, and man, we are always in there for emergencies, and it's really hard for me. So we want to make sure that we remove the term emergency. We'll talk about triage in a minute. Decide if it's a bond failure issue, if we need clinical training, or if we need a tracking system set up. So let's talk about some of those. So triage. Triage is the training that our front office gets, our schedulers get, to know who gets to be seen today. If a patient calls in and I've been out of treatment for 6 months and I have lost my retainer and I need to come in for a new retainer, I would recommend not scheduling that as emergency. That would be scheduled as an impression, a scan, whatever it is. So when we look at our emergency numbers, I want to know that they are truly what they are, which is patients that need to be seen today. My Herbst is out, I have a loose bracket, whatever it is. Once we know truly what is in our emergency bucket, that's when we can decide if we're going to implement a tracking system and say, hey, we need to find out what is happening with our high number of emergencies. Was it a specific office? Was it an assistant? Was it loose brackets or bands? Which tooth? Which adhesive? All of those pieces of information are going to help us put solutions in place that will get us out of this pot. If we just say, oh man, we have a lot of loose brackets, and that's the end of it, nothing's going to change. So we need to dig into that and find out what's happening. Now, if we have a lot of loose brackets or emergencies and we find out, nope, it's later in treatment, we may decide it's mostly a patient education issue that we're having, and we're not helping our patients by giving them education on what we can and can't eat, what we can and can't do. Or you can decide it's a clinical issue and maybe we need to reinforce or make our bonding protocol consistent. Good. There we go. So this is what I would use. If you find out your bracket, your bond failure rate or your wire poking rate is much higher than you want, Gaidge is going to give you that overall number that says, hey, this is where your level is. If you want to find out what's happening within that number, unfortunately, the solution would be to have something like a tracking slip or some way we can get information about what happened. When was the bond? How soon after the bond did the bracket come loose? That may determine whether it's an office bonding protocol or an eating issue with our patients. We want to know if there's loose brands, which brackets, where was the adhesive? If you're doing direct and indirect, which was it? Which one do we have more of an issue with? Once we have this information, then we can put it into an Excel sheet so we can break it down. We can tell what the problem was, what the repair date was, bond date. That's a big one, because I want to know between the bond date and the repair date, what was that time frame? I give offices about a month after a bond to put pressure on them to say, hey, this is probably a bonding protocol issue versus a patient compliance issue. So that's a big piece of information. If you have multiple doctors, the assistant, which tooth, that way you can determine, are we having issues with our posteriors or our anteriors, upper, lower, whatever it is. Brackets, if we're using different types of brackets. If you're using direct or indirect, that will help you. And where was the adhesive? And we'll talk about that. So guidelines, we need to decide who is going to be seen. Who gets a regular appointment? Are you going to charge? Probably the majority of my offices don't charge. It's not saying that this is the way to do it. This is just what I'm seeing across my offices. Most of them do not have additional charges for breakage unless it's an extreme. And many times what they will do is kind of threaten, if you have more than this many loose brackets, we're going to have to start to charge you. You can determine what your office wants to do. Now, there are times when I say, this may be one of those patients that we say, we need to discontinue treatment. We're not getting ahead. We're not gaining. You're frustrated. Mom is angry because she's taking off work, constantly coming in. So if we can isolate that it isn't our problem, that it's just not maybe a time for the patient, we may have to say, this is one of those, let's go ahead and discontinue treatment and restart when Johnny is in a better space. I know doctors hate to do that, but sometimes it's in the patient's best interest. When patients show up with breakage, we look at, where is the breakage? Is this a repeat offender, or where in there in treatment? If they are coming in and they have a loose bracket and it's the appointment right before their pan and repo or midway treatment evaluation, whatever, maybe we don't rebond that bracket. Maybe we wait until their next visit. We can rebond it at the repo. And then we look at what we had planned today. So we still have to fit within our appointment time frame. So if you have a 20-minute appointment, you can do what you can accomplish within that 20-minute appointment, but we still have to follow those guidelines. Look at today's schedule. After we evaluate today's procedure, then you can decide what you're going to do. You're going to repair only, reschedule. Can I do everything? Part of it is, if we look at today's schedule, if you look at the schedule and you say, boy, my 10 o'clock patient or appointment isn't filled, or we didn't fill that start for today, maybe I can use that time and I can go ahead and accomplish everything. So the goal is to accomplish as much as we can, not to penalize the patient, but to make sure we're moving treatment through as quickly as we can. We make sure we have a consistent bonding protocol, curing light maintenance, because our patients never do anything wrong. So your bonding protocol. When I work with offices, part of my protocol when I go into an office is say, especially if they're having bonding issues, is to say, do you have a consistent bonding protocol? And 95% of the time they will say, oh yes, we have a very consistent bonding protocol. And then I get to the office and I see 8 assistants and 8 different variations of what that bonding protocol is. So your bonding protocol, especially with team members, coming and going more frequently in the last couple of years, having that consistent written bonding protocol is critical. The other thing is, this needs to be reviewed periodically, like every couple of months during your clinical meeting or your staff meeting. Revisit it, get everybody back on track of what we're supposed to be doing, because a lot of times they drift away from it. So if you have adhesive on the bracket, if your report says most of the adhesive is on the bracket, then we can look at what are the problems or what are the causes of having that happen the majority of the time. Saliva on the tooth, etching is a big one. I see a lot of times team members will etch for 2 to 3 minutes. That the enamel rods get eaten away when we have it on that long. So it can be a much weaker bond. We can still get a bond, but it's going to be weaker, insufficient curing. But adhesive on the bracket generally means I'm looking at a bonding technique solution for this practice. If we have the majority of the adhesive on the tooth, I want to look at how the team members are placing the adhesive on the bracket. Is it bumped during the gel phase? What does your curing system look like? Your lights, your protocol. If we have it on both, a lot of times these are, it's not pushed into the mesh. A lot of adhesive on both. I can push harder on, the patient compliance issue with that. It's not as much a bonding issue as it possibly is more of a patient compliance issue. Now, I want to talk about isolation a little bit. If you were having trouble with that, there's all different types of isolation. We need to make sure that if you were having most of the adhesive on the bracket and not on your tooth, revisit what your isolation solution is. Nola cheek retractors. It's a love-hate relationship. I have offices that love them, and I have offices that said, nope, I hate those things. They're uncomfortable for the patients. Working as a clinician, Nola was the best way I felt to get complete isolation. I am in total control. The key to that is that tongue guard that is generally what bothers the patients is to make that a little bit shorter, drill some holes in it so that your suction is increased and make it more comfortable for the patients. If you want instructions on how to do that, at the end, you'll have my email. Send me an email and I'll send you instructions on how I did that. We need to make sure that they are being sterilized properly. Oftentimes there is blood in them. If it's rubbed on the, on the lingual side, they're autoclavable. So we want to make sure that we rinse, ultrasonic, rinse, package, put them in the autoclave, but they have to go in your autoclave on the plastics cycle. It's a lower temperature cycle, and again, if you need help with that, send me an email afterwards and we can get you helped. Light curing. We need to, make sure that your team members know how to light cure. Make sure it's the proper intensity and that we are getting that light behind the bracket to where the adhesive actually is. So we can't go from the facial side on a metal bracket. Test your curing lights. Some of the curing lights come with a meter on them. I want to know the exact milliwatt output of my light. So I don't trust those to know whether it's a green or a red because I don't know where that number lies on those tests. So I recommend having a curing light meter in your office and testing your lights. When you test your lights, make sure that when you are testing your light, so you'll have the meter, you'll put the tip right on top of it to test it. That's not how we cure a bracket. Our curing light is not that close. So we need to lift that light away from that meter about the distance that you would put the tip when you're curing a bracket. That's going to tell you the number that's getting to that bracket and that adhesive. Clean your tip to make sure there's no adhesive on it. And make sure that if you take that tip, you can read completely through that and see clearly. If you can't, that means that light is not able to transmit well. Now, this has nothing to do with getting a bracket to stick, but this is often how I see my clinicians curing brackets. This does not protect your eyes. Please use a large shield and orange safety glasses on your patients or orange safety glasses on the assistant. Please protect your eyes. Okay, talking about patients' overestimated completion date. This should be about 10% or less of your total patient base that are seen should be over their estimate or allowed to be over their estimated completion date. So we run our report, gives you a list of everybody that is over their estimated completion date, go through, clean it up, make sure that the date is correct, the statuses are correct, all of the information is good, then probably rerun it with accurate data. So this is in Gaidge. This is what your dashboard will show you. So it will show you the total number of patients over estimated completion date, and that will tell you how many are in which category. So this one has 75 that are 1 to 59 days over. But if you look at the 180 days over, there's 62 patients that are in there. That's dead wood. We need to get in there and clean that up, because those are your, I'm not wearing my elastics, I have a lot of breakage, and the doctor just thinks if we give them one more chance, they'll do it. Please, if they haven't done it by now, there's a high probability they aren't going to turn it around. So if you get this report, start looking at these patients that are the highest over their estimated completion date and start working your way down. Something happening with this practice is they've got 30% above same month last year that are over their estimated completion date. That's a flag. So these are numbers, when we see these metrics, those are ones that we really dive into and say, what's happening here? If you start to clean up your data. So this is an office I worked with, and in July I went in and then we started cleaning up data because they had a lot of that dead wood in there, that the statuses weren't correct. They were out of treatment. They never got deactivated. So we went in and cleaned things up. So if you see one of those big drops, if you're doing cleanup, that's good. Now, unfortunately, this office still has a lot of patients that are over estimated completion date by a lot, but we're also working our way down. They've got 845 that are over, but we're down 54% just doing that cleanup. So once we have good information, now we can start to figure out, what are we going to do about it? We know what impact it has on your office. We look like this a lot. If you have a lot of patients over estimated completion date, you're going to have a clogged up schedule. Because if your schedule is built for X amount of active patients, and you have, like that office, had 854 patients that were over their estimated completion date, those are taking appointments that your active patients, your true on treatment time patients need. This is going to force your schedulers to override, patients waiting, bad PR in the community. So one of the ways patients judges is by their metrics. Am I seen on time? Low emergencies. My treatment was completed on time, versus sometimes what the office judges as far as what's excellent treatment. And that's, we got them into class 1 occlusion. Well, if it took you 4 years on a 2-year treatment, that may be not in the patient's view of what is excellent. So you might have to find some balance there. So patients over estimated completion date, 10% or less, we set it up to meet our financial goals and to free up our schedule. So I look at over estimated completion date 2 ways. I want to look at how many are over estimated completion date, and then I want to look at your treatment efficiency monitors to help you determine how you got there. If we don't care how you got there and we just clean up the data, you're going to end up with that high number again because we didn't solve the problem. So this is your extended exceeds length of treatment by phase in your practice management. So it's going to tell you the name, status, start date, removal date, and their months in treatment. This is when you're going to get those flags of what the statuses are and if your triggers are in place or if codes are being posted. So if I have an office that has a higher number of patients over estimated completion date that we want to work on, I involve the team in doing it, because if it just falls on one person or the doctor, probably not going to happen. So 3 positions in your office. One is managing your patients overestimated, one is your daily manager, and one is your treatment efficiency manager. So the first one, managing patients that are over. They're going to run the report, clean up statuses, report trends. Hey, we've been working on this, and last month our overestimated completion date was at 32%. We are down to 30% now. So we are on the right track. And then make sure that our codes are being used correctly, that my clinicians know why we post a certain code and what that does for our numbers. The second one is our daily manager. So they're going to run the report of patients that are in overestimated completion date with an appointment scheduled the next week. That's when we're going to look at these appointments and say, how'd they get there? What's going on with them? So the day that they come in for their appointment, we're not going to the morning huddle and saying, Johnny's here today. He's coming in at 4 o'clock. He's at 32 months of his 24-month treatment. At 4 o'clock, we don't have time to process that and dig into how did we get there? So we look at those that are coming in the next week and say, how'd they get there? So when Johnny comes in at 4 o'clock, the assistant that is working with that patient can say, Johnny's here today. He's in 32 of 24 months. We're struggling with elastic compliance. Do we want to discontinue treatment? Have a plan instead of just show up. Johnny's here. He's over. Okay. Check. We'll see him again in 4 weeks or whatever. That's not helping you get out. That's adding time. You can run a morning huddle report that tells you who is coming in today. So once we have this report, then we can look back at that weekly report that says Johnny's coming in today at 4 o'clock, and whoever was working with him, here is what I found out about why we're over treatment, and here's my plan for what we're going to do about it. When you run these reports and you start looking at these statuses, you will notice if they are in a record status, they're probably not in overestimated completion date, or they shouldn't be in that status. An observation recall, they shouldn't be in there. And then we look at the time that they are overestimated completion. So if this is your morning huddle, I highly recommend that you spend some time and energy working on your morning huddle to make it an effective tool. So when we look at the morning huddle, we look at exams. Oftentimes when I go to a morning huddle, I will have the TC going through every exam that is coming in today, where they're coming from, what their issues are, what their insurance is, all of those things. The morning huddle is meant for what's going to get us through the day. Those pieces of information are what the TC gives to the doctor when they go into the exam. What's our rotation? So when we're scheduling, if we say, Christmas is coming and we are out in, oh my gosh, it's like 3 weeks, maybe less, 3 weeks. So don't send patients up with a 3-week rotation. Say we're out. If we have any openings in the schedule to fill. The start we have scheduled tomorrow has not filled yet. We look at the exams, opportunities to fill it. If there's not any, maybe we start to fill that with patients that need a pan and repo so we can push them through treatment. What are the starts for the day? Anything we need to know? Removals? Look at bottlenecks in the schedule and get a plan in place for what are we going to do about it? Rather than we just show up and, oh my gosh, doctors needed in the exam as well as the bond, and then we have a removal right at the same time. Look at those things ahead. And then we look at patients that are overestimated completion date that we've already checked. The third position is your treatment efficiency manager that's going to help you figure out how you got there. Look at the treatment efficiency monitor of all the patients that were debanded that month and see what you did. And then work with the doctor, especially if you're seeing your doctor is typically giving a 2-year treatment plan. But when we look at the treatment efficiency reports, we see that consistently this doctor is not able to do complete, impacted cuspid cases in the 24-month time. So we need to know you need to give them an accurate treatment time in the TC room. So in Gaidge, this is your estimated versus actual months to completion. So this is what this office did. Full treatment, they were saying they could do it in 24 months. They're doing it in 26 months on an average. Pretty good. I would say this office is very close. Aligners, 22 estimates and 22 completion, or 20 estimate, 22 completion. These numbers look good. I wouldn't be too concerned. This is an office I would be concerned about if I saw that you were typically saying, I can do a full treatment in 24 months, and consistently I'm completing that treatment in an average of 34 months. We need to look at what is going on either within that treatment or in my calculation of what I can complete in 24 months. This is a treatment efficiency report that you can fill out that will help you determine which treatments we are not completing in the right amount, in the estimated amount of time, and which ones do we need to adjust. So instead of just saying, in general, we are not completing those in that time, this will break it down to where you can really look at what's keeping you from completing those on time. So when we get that report, we look at which cases went right and which cases not necessarily went wrong, but I wasn't able to do what I said I was going to do. So we look at both of those. If we determine that we need to reduce the visits, then we're going to look at what do we need to do to reduce visits? Do you need treatment plans and efficient appointments? Do we need to look at self-ligation? If you were doing a lot of repositions, do we look at bracket options? Decreasing your emergencies. If we have multiple doctors, maybe we're looking at bonding options and moving to either indirect or computerized treatment planning. But with that information, now we can start and determine some solutions that are going to help us rather than just, man, we got a lot of patients over estimated completion date. So we look at our appointments. We have to make sure each of the appointments that a patient comes in for in our practice is an efficient movement through their treatment. I don't like appointments that are called check appointments. What are we checking? Well, let's do something to move treatment rather than just checking for eruption, checking for a cuspid coming down, unless it's an activation. So we need to make sure we look at the morning schedule. My team members are prepared for doctor. We're organized. We have consistent charting. And what are we going to do with additional procedures? So being prepared for doctor. My goal for my clinician is when your doctor comes to the chair, you anticipate what they are going to do. You have everything prepared because you have your chairside unit is organized with everything that you need. You evaluate the patient. Where are they in treatment? How's the oral hygiene compliance? Review the treatment plan. Know where we are in treatment. Guide the doctor. Your doctor is seeing all of the patients you see. If your office sees 80 patients a day, your doctor is seeing 80 patients. You are seeing a portion of those. So guiding your doctor through today's procedure by helping them where they are in treatment is going to move them through the day, as well as your patient's treatment, much more quickly. And a verbal script. So this is what I want your chairside unit to look like. My goal for my chairside assistants is you do not leave during a procedure. You have everything you need chairside that you can turn an appointment. You can grab extra things, extra instruments that the doctor wants, whatever it is. Have everything organized in your chairside unit so that you do not have to get up. Then we need consistent charting. I don't know how many offices I go to, and when I look into their charts, I worked chairside for 20 years. I should be able to go in and read your charts and get a general idea of where they are in treatment, what these terms mean, but I find it's all over the board. So we have to have everything documented, clear documentation of what was done, so that if I look at that chart, I know exactly what happened, who I talked to last time about poor oral hygiene, making sure our abbreviations are consistent. When we are bringing new team members in, they may either bring abbreviations from previous office or what they interpret. So you should have a list of abbreviations for your office so that everybody is charting everything the same. Make sure we know what our procedure codes are and when to use them, and our oral hygiene grading. Make sure everything is consistent. So if you determine that your treatment times need to be brought down, treatment plans can help you keep on track. There's basic plans out there. You can add specific information for your patient, but be specific in where you are. That way, when your clinician seats that patient, they can say, we are at 12 months into treatment. We should be at this point, whether it's pan and repo, whatever it is, based on that treatment plan. And they can help you by, when the doctor comes to the chair, the clinician can say, hey, Johnny's in 12 months of treatment. We have not even done pan and repo yet. We're going to be behind if we don't get on track. Or Johnny's at 12 months in treatment. We've already done the pan and repo. It looks like we are on track or ahead. So use these steps and plans to help guide you to get your treatment done on time. Build basic plans, but detail it, detailing what arch wires are we going to change. So if we're training a new clinician, they will know your arch wire sequence. If I am a clinician, I'll automatically know what arch wire we're generally going to be going to. So if I don't have a doctor at the chair right away, I can continue moving. Much more efficient. Using milestones, like I said, at the at halfway point, you should know where you are at about the halfway point in treatment. Are we going to do a progress pano, whatever that is, so we know when we hit those marks that, yeah, we're on track, or at least a heads up that we're not on track before we get to 24 months and we have to tell mom, we're 6 months behind and she hasn't heard a word of this. So make sure we set those milestones. We want to look at D-bands per start. The target is 1.2 to 1.3 starts per D-band. So that means your practice has a slight upward growth to it. If you have a lot more starts than your D-bands, you may be outgrowing your practice or outgrowing your schedule because you're starting more patients than you're getting out. If you have more D-bands than you have starts, we may need to look at why our starts down, unless we've done like a cleanup to where we're having a D-band month where we're getting all of this dead wood cleaned out. So those can kind of taint your numbers a little bit, but we want to make sure that we're on the right track or trajectory where you want the practice to be. If you have spikes like this, starts per D-band. So in December, you ran a special on $500 off for every start. You're going to see a big upward tick in your starts. That's not going to be keeping up with your D-bonds. If it's just a month because of a special or something like that, that's great. But if it's consistent and your D-bonds don't keep up, you're going to be in that. I have a lot of patients overestimated because I don't have time in my schedule for them. So when we look at efficient treatment, we look at the number of months in treatment, the number of visits, the number of emergency visits. That should be about $310 per visit. That's the average. So let's look at what Gaidge will tell us. So Gaidge will tell us for each of your treatments, the green side is the dollar value per visit based on the purple side, which is number of visits per that treatment. So you can see full treatment. We're at 367, 15 visits. That's great. Phase 1, 8, well, $415 a visit. This office looks like it's in pretty good shape. So this is a report that I would say, let me focus on other things. If this is your practice, this is a high impact area that we need to spend some time focusing on. You can see in this practice, their full treatment, their average was 16 visits, but based on their fees, their value per visit is $100, $103. We have to make sure it's not all about the money, but yes, we are in a business that we need to make money. Phase 1s, they're doing great, but phase 2 and aligners, we are still below what that average should be. So we need to look at what you're estimating and what your fee is to make sure that it is coming out that you were actually at 310 or at least around that. So your actions, take a look at your gauge, get in there and look at it, and don't just look at it. Dive into it and say, what numbers did she say we were supposed to be looking at? Where are they? Where am I compared to the averages? Run the reports in your practice management software to see what are your pain points. Are your statuses not tracking? What's going on? What's your emergency ratio look like? Look at it in Gaidge and decide, do I need to break it down more so we can put some solutions in place? If patients in extended treatment is one of your struggles in Gaidge, get those systems in place till we have something happening. Somebody is managing those rather than continually saying, man, we have a lot of patients in extended treatment. That's not getting us out of where we are. Make sure your morning huddle is effective and everybody is there. When you start your morning huddle, everybody is there, uniforms on, ready to start the day, not putting my lipstick on and eating my yogurt. Make sure that you have your clinic set up efficiently, your sterilization area. Make sure that everything is efficient and you can move people through treatment, their patients through treatment much more efficiently. So at this point, Malika, I'm going to, excuse me, take a drink of water, and then I'm going to open it up and see, did anybody have any questions regarding the information? Okay. Okay, some of the questions were, is every practice management system able to track each metric? Currently integrated with TOPS, Ortho2, Clouds9, Dolphin, OrthoTrack, and OrthoFi with daily uploads. Question is, does Gaidge track repairs by the appointment scheduled in Dolphin and the appointment completed from the treatment card? You can run a report from both, but it should be from the appointment completed because that's the one. Sometimes I don't care, or most of the time I don't care what an appointment is scheduled for. What I want is my clinicians to chart what actually happened. So if they were scheduled for, a short emergency and it turned into a long one with a broken bracket, that's what I want the codes changed for in their treatment card. So, and let's see. Malika, how are we doing with any other questions? Okay, is this going to be available and recorded and distributed out? And yes, it is being recorded and you should have access to the live recording shortly. And Malika is having some technical issues. So, okay, where in Gaidge can you see the starts during the starts versus D-band report? So in the report, there are the two areas that we talked about. One is the schedule and one is treatment efficiency. You're going to go into treatment efficiency, and that is where that report will live, is the starts versus D-bands. Best curing light in my opinion. There are some, I've had some issues with the Velo light. There's several, Allure has a new one out that is on the market that has been very well received in offices. A lot of the curing lights, I'm more concerned with care, maintenance, and making sure that the output is up to what we need it to be versus the actual light. So there's a lot on the market, but make sure that you're testing them and know what your milliwatt output is. So there's a question. I see exam starts, observation, and schedule. For that question for Jaden, maybe we can take a look at that because I'm not sure if you're under which tab you're under. You see exam starts, observation, and schedule. Another question, if the milliwatt has gone down, what do we do? Maintenance or throw it away? First thing I would do is your maintenance to make sure that it is up to date with your maintenance. And if not, then I would contact who you purchased it from and look at how long ago it was to see if there are any repairs that could be done. And if not, this one may be one of those critical pieces in our clinic that we need to look at investing in some new lights. So do your maintenance, check first. What is the difference between a repair visit versus a bond problem? Depends on how you have it set up for your tracking in Gaidge. So a repair visit is one that would be scheduled. The bond problem is what fits within a repair visit. So your repair visit is the total number for a month that has been recorded. Within that, then you can have 10% be bond problems, 10% be wire problems, 10% be broken appliances, whatever that is. But your repair visit is the total number, and then it's broken down beneath that. Malika's typing, and so I just want to see if she is doing okay. She was having technical issues. I was trying to see, there was one more question. I think I answered that one. Two more in the... Okay, Malika, all the questions have been answered. Thank you so much for today. Thanks for joining us. And you know what? We're going to see you all next year. So I want to thank everybody for joining us. Malika, I want to thank you for being here. I want to say happy holidays to everybody. And we will all see you next year. Thanks. Have a great rest of your day.